Now, we see in a lot of these trials, almost everything for EGFR cutoff is 30. Now, what would your take be on prescribing that to patients with an EGFR sort of approaching that mark? Is it an immediate no-go for you, or what kind of factors do you take into consideration then?
Yeah, it is a very interesting intersection of these SGLT2 inhibitors, EGFR and BRISC. The SGLT2 inhibitors, very similar actually to the renin-angiotensin system inhibitors, cause a transient dip in EGFR and then subsequently allow for long-term kidney protection. And while at low EGFRs, many clinicians may be cautious about using these therapies. In fact, they're actually quite effective, and now we have dedicated chronic kidney disease studies that have shown they're not only effective, but life-saving in many cases. And so I think that part of this needs to be coupled with education to clinicians that this dip is expected, that long-term the EGFR is expected to stabilize and even plateau and prevent further decline. And then I think also we need to broaden education that these aren't necessarily kidney toxic, meaning that there's no evidence that these are actually injurious or causing permanent kidney injury. That transient EGFR is a physiological effect that's expected and anticipated at the level of the glomerulus and is reversible and plateaus over time. The individual cutoffs for each randomized clinical trial does vary. In general, they've been about, in recent trials, have gone down to an EGFR of 20, for instance, in the Emperor-reduced trial, or 25 in DAPA-CKD. And so I think we're learning that the safety profile can be extended well to low EGFR ranges. And so if you are caring for a patient on an SGLT2 inhibitor with progressive chronic kidney disease, consistent with these trial protocols, these therapies were not disrupted unless the patient was initiated on hemodialysis. And so I think that should be our clinical practice as well, that they should be continued, and they still do offer a cardiorenal protection well down to a low EGFR. Unless these patients are started on dialysis, I think they can be maintained in clinical practice.
Is there anything else that the more recent SGLT2 studies add to our understanding of these that you want to touch on, specifically VERTIS-CV, DAPA-CKD, and Emperor-reduced?
Yes, I think it's been remarkable, and it was actually quite challenging to write this scientific statement because we understood we were on unsteady ground with a rapidly evolving evidence base, and so this scientific statement is actually accompanied by a commentary as well as an updated slide set to allow for clinicians to actually go through some of the more recent advances, including publications within the last 1 to 2 months in the New England Journal of Medicine. So I think that based on the totality of evidence, it's very clear that one, the SGLT2 inhibitors have an important cardioprotective role in high-risk type 2 diabetes. Two, they have a clear role in treating patients with albuminuric chronic kidney disease, meaning chronic kidney disease with high albuminuria, with or without type 2 diabetes. And three, they have a very clear role in treating heart failure with reduced ejection fraction with or without diabetes. Now, open questions that are being examined in ongoing clinical trials are, one, patients who are early after myocardial infarction who have not developed overt heart failure or don't have other treatment indications for SGLT2 inhibitors. So that post-MI setting, I think, will be very interesting, is underway. Heart failure with preserved ejection fraction, the other 50% of the cohort with heart failure, very high risk cohort without current treatment options, also being actively pursued. Non-albuminic chronic kidney disease, these are chronic kidney disease patients with lower levels of albuminuria, is being tested in another randomized clinical trial. And then Other clinical trials are assessing patients who are hospitalized for heart failure, for acute decompensations of heart failure. And I think we'll learn more about their safety and efficacy in that high risk setting. And then finally, a trial that's due to report very shortly of COVID-19 and the effects of dapagliflozin in that high risk setting. So I think we're about halfway through in terms of the wealth of data that's emerging. We've learned a tremendous amount already about the foundational role of these therapies across cardiometabolic and kidney disease states. And now we're poised to expand that knowledge.